Thank you very much for the kind invitation. It's a pleasure to be with you. Thank you, Rob, this fantastic talk. I think more than anything, there is no competition in the sense that trying to prove if RSV or Rhino C is a more significant significantly associated with recurrent wheeze or asthma, because each of them have their own role in all that. I'm going to discuss with you. Okay, let me just. Okay, the impact of RSV throughout life, as you all know, is quite broad, and early in life, we all, pediatricians or pediatric pulmonologists who deal with children, know how important it is, RSV in the early life impact with severe bronchiolitis syndromes. And somehow it has a much less impact later on in life. And again, after the age of 65, it has recently been acknowledged that RSV again starts to be significantly associated with disease, especially in people who are who have comorbidities and are at greater risk for severe disease. So all new therapeutics aimed at RSV at this point will, and you'll be seeing in the next years, and I'm going to discuss a bit by the end of my talk, is aimed at in the first, especially in the first year of life, and then again for the elderly. Still, Still, RSV early in life may not necessarily be associated with asthma or with the asthma that Dr. Lemansky has just mentioned, the atopic, more severe, more persistent asthma. We know that, that there is an association. I'm going to show you data in that direction. But this association may not be causal. And we know that severe infection in children is associated with recurrent wheeze. But this recurrent wheeze and asthma, as we know today, and Rob has just shown how complex the interaction between virus, microbiome, and genetics play, and they somehow create different endotypes or different phenotypes that will respond differently to these associations. So the role of significant RSV early in life may be enough to warrant that prevention of severe RSV disease is a goal that we should be looking at. But like for COVID, and we're all seeing that in the past year and a half, only a few children will present severe forms of RSV disease. Very few will need hospitalization, and even less of those will go on to need more aggressive ventilatory support. And we all know that there are clinical phenotypes, and I'm going to show you later on that the clinical phenotypes are not enough to define targets for therapeutics. There may not be enough, but some of those clinical phenotypes are absolutely key and well understood. The most significant is that of preterm babies, being this the target of what we have so far in the market as the monoclonal antibodies specific for RSV. As you can see, when we look at this specific phenotype of preterm babies, you can see that they're clearly, if you have preterm babies under the age of 1, this is where the greatest risk for hospital admissions is. But you can see that those who are under 6 months present a very great risk in general, and the risk goes on up to 2 years, and then it goes down significantly. Also, when you look at this systematic analysis, looking at risk factors for RSV and wheezing later on in life, you can see that there are specific groups that are at greater risk. Those with chronic lung disease, congenital lung disease, heart disease, I'm sorry, those preterms under 32 weeks of age, and of course, kids below the age of 3 months and below the 6 months of age are at risk for disease associated with significant RSV disease. But as I mentioned before, not all phenotypes are clearly assessed, and we definitely have data at this point that at least one of the major underlying pathophysiological causes is well detected, and this is lung function when measured very early on in life. This is now somehow classic data that Marcus Jones, who works with me, has shown a while back, that healthy preterm babies, because of the architecture of the specific architecture of their airways and their preterm birth, they have lower lung volumes, lower flows. So somehow when RSV strikes this population, we can detect lower flows as an associated and very likely causal that antecedes, that precedes RSV, is already there and is related to those kids being more likely to wheeze. Kids who have 2 or more LRIs, in comparison to those who never had wheezing LRIs or had at least one, they have lower lung function. So if you have a kid who is wheezing more frequently, when you see this kid in your clinic and the kid is born preterm, it's very likely that it will have lower airway flows as a cause for wheezing. So it's the combination of a virus that is quite aggressive in terms of inflammation and the as I mentioned, the architecture of the airways. Interestingly enough, when we followed those kids for a year and a half or 2, those kids, their lung function continues to track as if once you're born in a lower path, a lower channel for lung function, you will continue to do so for the longest time, probably forever, but the real impact for that is early on in life, and probably for some, again, after age 65. So that's why the link, there may be a link of lung function and RSV early on in life and later on in life, explained by lung function. And this is data from the the Tucson study suggesting exactly that low lung function in infancy relates very well with lung function in adult life. So one of the explanations, or at least for one specific endotype, lung function may explain quite likely the presence of wheezing early on in life and then later. This is very, very interesting and recent data from Heather Czar in South Africa in their birth cohort, when they looked at the RSV LRTIs in association with recurrent wheezing, and they've seen that there was 3 times greater risk for developing recurrent LRTIs versus those who had non-RSV LRTIs. But this was particularly significantly for those who had severe RSV LRTIs. So it's important not only that you have RSV, but you have to have a disease that is significant enough to be admitted. And there was an association between RSV LRTIs with this, as I mentioned, recurrent episodes, especially if the child has been admitted. But it's not only LRTI, and could very well be Rhino or Rhino C, as Rob was showing, because kids who were hospitalized, independent of that being RSV or not, are more likely to have recurrent wheeze. And this is shown in this graph when you have kids who were hospitalized. So if you're RSV negative and you're hospitalized, or if you're RSV positive and you're hospitalized, you have this red and blue lines here that are represented here by red and blue lines. You see those are the ones who are more likely to have recurrent wheeze. So yes, there is an association of impairments in lung function that is not exclusively related to RSV. So those are quite complex interactions that we have to account for. This is data from the British and Australian cohorts looking at risk factors associated with this low lung function trajectories, and this analysis here, you can see that maternal asthma, severe RSV LRTI in the first year of life, and active asthma at age 32 are independently identified as risk factor for having low lung function early on in life and continue to have low lung function throughout adult life. Not all people who have low lung function will wheeze, but this is a significant marker associated with wheeze for some specific groups. This is again data from Adnan's Chustovic's group in the UK, using cluster analysis to look at longitudinal trajectories, and I like very much this data because they identified by this computational mathematical approach, not logical, not based in clinical evaluations, two different groups of those who had infrequent exacerbations and those who had early onset frequent exacerbations. And you can clearly see by the number of exacerbations that those who were clustered in the early onset frequent exacerbations are clearly separated from those who have infrequent exacerbations. This B cluster here has, and you can see that in the table here on your right, that they are more likely to have low lung function in comparison with those who have infrequent exacerbations. And also the risk factors are different in relation to breastfeeding, to eczema at age 1, age 3. You can definitely see that the numbers are much greater in those who are frequent, who have frequent exacerbation. They're more likely to be atopic, to have an asthma diagnosis by a physician, to be on inhaled steroids, and of course to have persistent wheeze. So when we use these mathematical models, we can clearly or more clearly understand that somehow those are different diseases. And the approach, the therapeutic approach, this is the interesting news in the last 5 to 10 years, is that evaluating subjects just because they wheeze as if they had one single disease explained by unique pathophysiological pathways is far from the truth. So the idea that we have complex syndromes, both for wheeze early in life and what will become asthma is very challenging at this point. We have written several papers have been written in that direction in the past years. But I want to sell you the idea that wheeze early in life is a series of complex and different diseases that may vary from factors that are related to lung function, but also to immune and inflammatory response. And I'm not going to enter into that, but it's quite interesting aspect that we have to take into account. And when you try to combine this early early life wheezing endotypes with the asthmas that we identify nowadays later on in life, those are very complex interactions. So to prevent asthma with a single bullet is far from what we understand those diseases are nowadays. We wrote a while back, I think last year, this paper that we jokingly said the syndrome we agreed to call bronchiolitis, that I wrote with Adnan and Fernando Pollack, exactly discussing that we can't put all into under one single entity. So trying to create links between early wheezing life and asthma asthmas is a quite difficult task. I like very much this data, and I'm sure that Sejal is going to talk to you tomorrow, and she probably will mention that, but I cannot finish that without mentioning this paper, that study that they did in preschool wheeze. And preschool wheeze may be in the inception of what we'll find as teenage or adult asthma, but it may contain different phenotypes than you'll find later on in life. But what they did is that they took 136 children that had very severe wheeze. They were all under the age of 6. And they got, and they called this recurrent severe wheeze, and they got a control group of non-wheeze children who needed bronchoscopy for different reasons, for croup or severe croup or laryngeal spasm, whatever other reasons, and they bronchoscoped and they cultured the airways, and they also phenotype clinically these children. So remember, they are all very severe. So it's not our common patient that we see in clinic every day. Those are very severe patients. Still, what they couldn't find or they couldn't cluster those children just using clinical phenotypes. So when they moved into using this mathematical clustering methods for analyzing unbiased these populations, they came up with these 4 clusters. One of those of atopic children who have the highest prevalence of sensitization, highest blood eosinophils. They were using inhaled steroids quite often, and they had a moderate rate of bacterial and viral detection. Still, they were very much dominated by Moraxella. Then they had a non-atopic with low infection rate and high inhaled steroids. Those had low levels of BAL neutrophils, low rates of positive bacteria, and lowest viral detections. Then another cluster of, again, non-atopic, but with high infection rate. They had high rates of Haemophilus, staph, and strep, different than this group of non-atopic, low infection rate, who of course were not on inhaled steroids, and they had the largest group of non-atopic children. So again, those were all kids who were wheezing, and somehow they have completely different biomarkers. Some of those children may very likely benefit of therapies that are aimed at using antibiotics. So if you have a lot of Haemophilus, staph, and strep in your lower airways and you're non-atopic, you may likely get better if you get an antibiotics, or if you have Moraxella, and you're atopic, you may benefit of some antibiotic approach here. So again, we're just starting to untangle this quite complex syndromes. So preschool wheeze, and most of those preschool wheezers are transient wheezers. It's a different animal. Again, if we take apart the preterm recurrent wheeze, this is again a subset of preschool wheeze that is again completely different, and the approach for that cannot be that of asthma. We cannot think of treating those kids with bronchodilators and inhaled steroids as if we were thinking they have asthma. It's a completely different background. How to determine risk for severe outcomes? We need definitely to look for biomarkers and better identify those groups for different strategies. So what are now, and this is for me to close and give you an idea of where are we going in the next few years. So what are possible preventive strategies for this complex syndromes? This is data from Louis Bond that many of you probably know, and they did give palivizumab in this proof of concept study to late preterm babies, and they saw that when they followed those kids with no other comorbidities, they followed them for a year. There was a significant reduction in hospital admissions and wheezing days. So somehow Pali has protected recurrent wheeze. So protecting the severe episode somehow protects the following episodes. But this protective effect, they have not observed at age 5 to 6 years, and that may be because of different reasons, but the main impact of probably preventing recurrent wheeze occurs in the first years, the first 5 years of life. The good news is that we have a better drug than Pali is. Just around the corner, the results of the studies with nirsevimab, which is the follow-up of Pali, but a drug that can be given only once in the beginning of the RSV season, are quite nice. This is data from preterm infants, and you can see that the reduction of significant RSV LRTIs is greater than with Pali. Pali was at most 50%, with nirsevimab is 70%, and hospital admissions is almost 80% lower. There's newer data for this drug in kids who are not yet published, in kids who are born at term, and the results seem quite interesting and positive. So we may have a new drug in the market in the next couple of years that may prevent recurrent wheeze by preventing significant RSV LRTIs in the first months of life, that at least for the first 5 years of life could have a significant impact. If that will have a significant impact on asthma or in later wheeze, it's yet to be seen. But it may be so that it protects one of the pathways for asthma that is led by RSV. Then there are RSV vaccination, and this is data from the Novavax study that didn't show to be that great, but still there are data from that study that vaccinating moms during pregnancy may likely have a significant protective effect of severe RSV early in life and subsequent wheeze in the following years. There are several of those vaccines in phase 3 trials that are currently running, and the results, quite frankly, probably are going to be very, very good. One would expect from the preliminary data that we're seeing. So yes, we'll have something on that. The other is data on immune modulation by OM85. There are very serious groups working with the idea that you can stimulate somehow, and Rob has shown how important the immune response due to this microbiome interaction is, and interferon seems to be a key player, key cytokine on that, and OM85 seems to stimulate the production, among other things, stimulate significantly the production of interferons. There are several studies currently going on. You know very well, your Chilean friend, Fernando Martinez, is the PI of a large multi-center study that Rob is also involved with in the US, with the idea that OM85 can prevent recurrent wheeze and asthma. There is data from Peter Lesweb's group in Australia also looking at prevention of recurrent wheeze in preschool wheeze through OM85. There is data from, there's a study by Jonathan Grigg and his group in the UK looking at the impact of BV in kids who have had severe bronchiolitis. So it's a completely new market out there. Those are complex syndromes, and somehow the way we will have in the next future to deal with these diseases are like broad impact therapeutics that may not be that specific. There's room for everything at this point. Thank you very much. I think